very much for arriving on a Sunday morning by 9:30 or 10 a.m. Many of us on different continents than we were 36 hours ago. I appreciate Andrew's comments because the first 30 years of my career, which I actually spent performing those single-dose clinical trials, many of them were performed in dental pain, post-operative dental impaction pain, where there is the greatest profusion of acute pain data. And then for about 7 years, I operated in pressure cooker. And the pressure cooker was a contract research organization called CYREX, where we had 7 clinical research centers. Sometimes we had, in those 7 centers, we might have 4 or 5 research projects ongoing. And 99 out of 102 studies, we demonstrated assay sensitivity. That is, we separated placebo from whatever the standard was, or we demonstrated a dose response curve, which was almost unprecedented. And then we crossed the hall and talked to our colleagues who were doing studies in chronic pain and realized the problems that they had was that many of the drugs that had been approved in a number of registration trials, but there were follow-up trials in other forms of neuropathic pain that didn't work. And when the start of this IMMPACT group, appropriately enough, was at this meeting 12 years ago, when 2 of my colleagues, Bob Dworkin and Dennis Turk, sat through about 3 meetings where various investigators were presenting the results of their work on neuropathic pain or osteoarthritis. And they realized that as reviewers, they could not make heads or tails of the data. The methods were different. The outcomes that were being studied were different. There appeared to be very few standards about how long those studies were going to be conducted. And that began a collaboration. And what I'll do this morning is talk to you a little bit about what these collaborations are, because they offer some very interesting opportunities to understand how data is utilized. They do a few uncomfortable things. We've asked a number of very uncomfortable questions. So, well, wait a minute, you guys are scientific geeks. You're used to asking difficult questions. Yeah, but we ask questions about what the investigators report someday. Do they agree with the way the study was conducted? We've just completed an analysis of the results of temporomandibular disorder pain, where we looked at 90 studies and realized that fewer than 25% of those studies ever reported any harms that were done by either the medications or the interventions. And so, let's go back to 30,000 feet for just a second and talk about these organizations and talk about how did it start, what were the initial questions, and let me see if I can move forward. Yes, I can. So what are these collaborations? How were they developed? I've told you why. Because initially, the founders of these collaborations, Dworkin and Turk, realized it was almost impossible to do combinations of data, to even actually look at meta-analyses like Andrew mentioned, because the methods were so different. How did these collaborations organize, and how do they accomplish their actions, and have they made a difference? Or, as my colleague Dan Card frequently does, he captures them in a nice, interesting turn of phrase. What are the actions of action, and what's the impact of impact? So thank you, Dan. I would have never been that creative. And I won't take any credit for the title. So, IMMPACT, one of the things you realize is that Bob Dworkin loves to play word games. I think he must do the New York Times word puzzle, crossword puzzle, 6 days a week. And so IMMPACT was the initiatives on methods, measurement, pain assessment in clinical trials. The focus of that initially was on clinical trials in chronic pain. It started 12 years ago, and until about 2 or 3 years ago, it actually existed as a separate organization. It was initiated by the 2 individuals that I mentioned, and interestingly, they sought pharmaceutical company support to do the initiative. And as we'll talk about in just a second, it's just as important to discuss what they did not do. And what they did not do, we'll mention a little bit later. That collaboration, and I'll talk about who was in the collaboration as well, has now extended beyond just measuring and coming up with methods for analgesic methods. It's been incorporated into a broader coalition called Analgesic, Anesthetic, and Addiction Clinical Trial, Translations, Innovations, Opportunities, and Networks. And that set of collaborations has now been developed with the assistance. They've gotten a couple of grants from U.S. Food and Drug Administration to focus on the type of problems that the FDA has been focused upon in terms of those interventions. So who were the collaborators? Who participated with this? Well, initially it started with a number of academic faculty, members of FDA, and then they began to enlist collaborators who came from other types of federal agencies, both in the U.S. And right now we're pretty well represented by a number of European investigators from both EMA, IMMPACT, and Europain. But again, at the heart of it has been some industry sponsorship. And anytime you accept industry money, the question becomes how much bias is there within the organization. So let me tell you at the outset that we don't talk about individual drugs other than how they illustrate a principle about how the drugs are going to be studied. Nor do they buy any influence at the regulatory level. But one of the fundamental disconnects, which we heard from our colleagues, and in particular Bob Rappaport, was that the FDA reflects the state of current thinking of clinical management of pain, but they're frequently disconnected. There are members of FDA who haven't been to a scientific or a clinical meeting in 10 years. And so this was an opportunity to bring the medical reviewers together with the scientists who were doing the study to talk about the methods. What are the strength of the methods, where are the limitations, and where are the problems? So those collaborators get together. Their mission was to identify, prioritize, they actually sponsor, and they coordinate sets of studies using evidence-based principles. And they now are focused, and they've always had a special interest in optimizing clinical trial designs. And what you realize is that when you talk about analgesic drugs, there are several interesting decisions that are made with the same data. So many of you, and some of the questions reflected this after Andrew's talk, have questions about how do I deal with an individual patient after a certain procedure. So what are my treatment protocols, which are fine. It's absolutely legitimate questions that individuals have. When I worked in actually designing and still work in conducting clinical trials and analyzing those results, the purposes for different purposes. They're registration purposes. What does my clinical trial, how does my clinical trial need to be designed so that in this trial I can meet the registration standards to get that drug registered? The other issues that also come about in those clinical trials have to do with those of us who do it for 10 or 12 or 15 or 30 years and saying repeatedly, I see a certain type of trial where essentially it's like trying to climb Mount Kilimanjaro. That if you're trying to show a combination of drugs work, how big does a clinical trial have to be to demonstrate that caffeine is going to have an effect? Well, that is rather a very difficult trial. There are very few trials that have ever shown that in any single small group of patients you can actually have a demonstrable effect of caffeine. So, one of the things that I wanted to bring you to was the Action. Action actually has a website. where if you want more details about the organization and how does it work and what studies does it conduct, you can go back to www.action.org. Or, as our former president used to say, www, which I never knew what that letter was myself, so I must have lived too close to Boston. Why has this collaboration taken off? In part, it's been captured by Janet Woodcock, who is one of the long-term influential scientists at the Food and Drug Administration, who wrote a couple of years ago that said science-based necessary to evaluate and predict the safety and efficacy of drugs and devices is different from the science that generates new ideas for a new biologic, a new drug, or a new device. That is, we have a lot of scientists at the National Institutes of Health and in many different universities who are looking at fundamental mechanisms, and there really is a critical need for those individuals to discover molecules or devices or individual types of technology that can help patients. But the challenge is, many times, there has not been a systematic review about the methodology, about how do we improve the methodology to study those devices. And so these initiatives sprung up as there was a recognition to train young scientists to be able to look at them. So let's talk a little bit about how they do their work, both impact and action. They generally hold small consensus meetings of international experts that represent both academic investigators, governments, both US, European. Interestingly, we haven't had much representation from South American regulators or scientists, professional societies, anesthesiologists, orthopedics, rheumatology, and patient advocates that sit in the same room. And a challenging issue is how many people do you bring together to try to make any progress. These meetings have generally been limited to about 30 individuals who have published in that particular area. After their outcomes or their findings, they're actually published in archival journals and they're made available to the rest of the world. But what ended up happening initially, we actually had to prepare databases and standards for even coding the studies. That, as Andrew knows, but probably few of us who work in the area trying to do meta-analyses, unless you can code similar studies or dissimilar studies and have a common language, you can't combine them to actually come up with any long-term conclusions. The collaboration also publishes systematic reviews. They perform meta-analysis as well. And the stage where we are at 10 or 12 years now is asking questions like, do our published trials meet established standards for collecting, analyzing, and reporting study results? And as you'll see, whether you report the same results you got is not an automatic conclusion once you systematically review the data. I'll come back to that principle in a second. That sometimes the answers we get are a little embarrassing to us when we talk about the community of pain scientists and what we publish. So at this point, there have been, in the last 12 years, 17 consensus meetings. There usually is a planning group of scientists that collaborate to make sure we're asking the right questions. A group of speakers are invited to stimulate discussion. They'll usually present their people much like and present talks similar to what Andrew presented. Here's the state of the art. Here's what we think we have. Here are the questions that we think are critical. And then the people who participate are experts either in performing those clinical trials, analyzing those clinical trials, or they have overviews of many of those trials in the past. One of the critical pieces is managing the potential conflict of interest. So there actually are declarations about what the conflicts of interest, if there are individuals that have a particular drug before FDA at that time, they need to be able to declare that at that particular time. And across the board, once the group finishes its work, and work is rarely completed at the end of that consensus meeting, the work happens in the next 3 to 6 months, we broadly publish the findings and recommendations, usually in pain, but occasionally in other journals. And I'm not sure if you can see what the red letters are, the red lines are here. What these collaborations do not do is focus on individual drugs or devices, and they do not lobby regulators. These are not meetings where you have little one-on-one conversations with the regulatory scientists. So let's go back again. We'll go back to 30,000 feet or 10,000 meters. And where is the harm and where is the good that comes from clinical trials? Well, I think we can probably agree when you look at an outline like this. We've all seen these 2x2 tables, right? So we can also agree that the benefit to society for doing these studies are in the top right, the true positives and the true negatives. If a study demonstrates that a treatment isn't effective, and that's the truth, that's fantastic. And similarly, if a drug is effective and you can demonstrate it in a clinical trial, ideal outline. Where do clinical trials do harm? I think you can also agree that if you're generating a false positive, that is, you're saying a particular intervention or medical device works, and really it doesn't work, you're doing a disservice to the public because someone is going to be ultimately paying for a treatment that doesn't work. And so what type of studies can be performed to try to detect false positives? So one of the interesting set of research projects that was conducted had to do with whether there were selective outcomes that were being reported in clinical trials. And there were several sub-questions. Were the pre-specified primary outcome measures, that is, if you're registering a new product and you're going to do a clinical trial, you have to decide before the start of the study, what is your primary measure of efficacy? And if that measure of efficacy fails to separate P.05, and you've got other arguments to make later as well, none of the other conclusions of the study would be accepted by a regulatory party, and the study is labeled a failed study. So the question is, were pre-specified in some of these articles, were there pre-specified outcomes analysis? Was the final statistical analysis performed on the same population that was decided in the protocol? Was that the final results that were presented? And ultimately, asking other questions, was missing data appropriately identified? Were the mechanisms to identify missing data identified? And if there were subgroup analyses, if this drug really worked better for patients who had severe pain, the worst of the worst, patients who had VAS scores from 7 to 9, were those analyses pre-specified? Or was that data dredging at the end of the study where you're looking to try to find an answer that maybe you have a negative study, but you're looking for the subgroup where it worked? Now, if you've ever worked in clinical trials, you realize that no matter when there is a negative trial that didn't separate, the immediate knee-jerk reaction is, we need to go back and look for those patients in whom it worked, because maybe we just didn't do the study right. We had too many of those insensitive patients. So this was the paper which was published in 2012. I'm sorry, I don't have the years on here right now. Were there discrepancies between registered and primary outcome specifications and analgesic trial? So fundamentally, were there differences between what was in the protocol, which was on the clinicaltrials.gov's site, and what was finally reported in a scientific journal? Interestingly, in close to 80%, 69 of the 87 studies that met the criteria for looking at this, those primary outcome specifications didn't match what was in the protocol that was listed on clinicaltrials.gov. And in some cases, there was no, in the registry, there was not a primary outcome, or in the publication, there was no primary outcome. So you couldn't answer the question, did it meet its primary criteria? Sometimes there was just differences in language. So there was a little bit of ambiguity about, does the primary outcome, did they choose a couple of different words but they meant the same? But in some of these outcomes, the registered primary outcome, that is, the primary outcome that was listed on clinicaltrials.gov, was not the same as what was in the publication. In 5 of these 87, the registered primary outcome was omitted from the publication, so it never made it to the publication. Occasionally, the publication included a new primary outcome, maybe giving the benefit of the doubt to the authors. Maybe they changed the primary outcome after an interim analysis, but it was never changed on the registry. And if you review both, there's another discrepancy. And the greatest proportion, 16 of them, the timing of the primary outcome assessment differed. So on one publication, it might have said that SPID 0 through 6 is my primary. Well, lo and behold, on the publication, 0 through 12 is the primary outcome. So in 30% of these papers, there was unambiguous discrepancies that existed. And so part of what the collaboration is trying to do, what happens when you publish these results? Well, all of a sudden, journal editors on the 3 or 4 journals where most of these articles are published, they look at these as well. And it sort of affects what they ask for in later publications. And some of them will actually, not only do they ask you to list what your clinicaltrials.gov registry number is, they'll go back and they'll review it. Does it agree? And how come that, why is there a discrepancy? Another area which is particularly difficult for the pharmaceutical industry and for the medical device industry are studies in which there are false negatives. And interestingly, and I thank Bob Dworkin for this information, in the past 4 years, there have been 22 negative neuropathic neuropathic pain trials. There are many, many others, but these 22 probably represent the equivalent of $80 to $100 billion of work and investment by some firms working in those areas. And many of these are drugs that are already registered for neuropathic pain. So the question is, why did those studies fail? Is there common methodologic flaws that exist in some of those studies? And interestingly, we probably never know what ultimately caused those negative results. For example, we know that some of the drugs may not be efficacious in those particular subconditions they were looking at. Those patients may have had long-term pain that is not going to be relieved by any intervention. Others may actually be false negatives, where the drug might be perfectly fine, but the methodology is flawed. And when you have a sometimes a flawed methodology floors the investigators. But a common example that I've seen, and the illustration we've used about methodology, use the corollary to Andrew's example. Suppose you bring a basketball team in, and the ceiling is set at 2 meters. Well, the whole basketball team looks like they're 6 feet tall. In fact, some might be 7, some might be 7.5. But in a clinical trial, if your study methods are incapable of separating the better analgesic drugs from the worse analgesic, we talk about having a model-imposed failure of the study. And the question is, does this only happen in pain? Well, it turns out it doesn't happen only in pain. It turns out that if you look at depression trials, over 50% of depression trials fail. And how is it discussed by the investigators when they have a clinical trial? What are the most common quotes that you have? Well, the placebo group worked too well. Too much effect on my placebo group. You've never heard that before, right? Optimal pain patients, and it may turn out we just don't know the pain phenotypes. What we think were patients which were all of one clinical subtype may actually represent 3 or 4 different types of disorders. Interestingly, the temporal changes in those patients, the baseline might be changing. And all of a sudden, you're imposing an intervention at a time where their cyclical pain might be dropping. And if you have patients who also have depression and you're entering the darkest part of the year, well, lo and behold, what a surprise that depressed patients get more depressed in the late fall and early winter, right? And the other big difference that we've seen, one of the things that we've seen, is that the larger the number of clinical study sites, the more difficult it is to separate. And why are there large numbers of clinical centers on some of these big studies? Because 1 or 2 or 3 centers can't recruit enough patients to enter that study. If you can come up with 3, 4 or 5 patients to complete a clinical trial, and that's all, by default, you're going to end up with 20 study sites. And then the inter-site differences begin to take over. So, how do you tackle the problem to begin with? Once we started talking about the problem, it turned out that we had to have a comprehensive registry of analgesic clinical trials. And those were available both from government sites and industry websites. And there was a whole group that pulled together what is referred to as a REACT database. So you can actually go back and you know what the clinical trials. And unless you've done this work, it's at times impossible to tell if you're dealing with the same clinical trial or 3 clinical trials that have 3 different numbers. So many times you could have one trial, but it generates 3 times the amount of data. Whoa, time out. If those are the same, someone's got to consolidate it and say, this is the same trial, we're going to count it once in our database. The second thing that the group did, and this took about a year, was we developed a pain-specific database standard, a CDISC standard, for retrospectively pooling some of those clinical trials. And you would think that this would be easy. Viru and I worked at Pfizer. It took us 6 months to get people at Pfizer to agree to share the results of their clinical trials to be able to put into this database. But we had to assure that the results would be anonymized over time and that we would look at methodology. It wasn't going to go back and slam some earlier drug. And what you realize is that everybody's protective about their data. You don't want somebody coming back to analyze your data and draw different conclusions, in particular in commercialized projects. So the results of that, and sort of what it looks like, what the REACT database has also been published in PAIN. The collaborators that worked on that project are listed here. And the CDISC format for how it would be done, what would be done, essentially involved probably close to 20 investigators who work both in companies, in academic settings, and how do you do it? It's sitting out there in public. So the issue of transparency for what those results are sitting out there. More difficult, sort of way the rubber met the road later, was actually to conduct some meta-analyses of study-level data between published and publicly available clinical trials. Most of the early work was in chronic pain conditions like neuropathic or osteoarthritis pain. And they've now started looking at some acute postoperative pain data as well. And then ultimately, once the latest group, Action, got involved, FDA decided that they would make available data that was sitting in their files as well, anonymized data on clinical trials that could be used, where you could use this database to indicate which of these studies were single dose or multiple dose studies. And we're in the midst of this right now. Among the questions that are being asked are there methodologic features of clinical trials and assay sensitivity? In other words, a common question that we're asked by companies, by individual investigators, is that if you do crossover trials, you really should be able to markedly limit the variance in those type of trials compared to parallel designs, because they're the same patients. You're going to get both treatments. Beautiful hypothesis. The statisticians love crossover studies. Many of the clinicians don't believe it really is an easier study and the variance changes over time. Well, what other characteristics affect assay sensitivity between doing crossover or parallel design? Is instructing subjects before they come into a study, does that help or does that hinder assay sensitivity? Are there ways that we can modify these studies to actually reduce the placebo response over time, to increase the likelihood of seeing a signal from your drug? Well, we made a list of the type of study characteristics that might be able to be examined in a systematic fashion. And I've only highlighted in yellow the ones that we've started to work on. But if you just look at, for just a second, the patient factors, does it matter if patients have a pain duration of 2 months versus 2 years? And what their response will be to drugs? Does the maximum amount, what's the maximum amount you should allow patients before they can enter into a clinical trial? Is there a minimum amount? Are we just going to accept the 3-month definition that we've accepted for years? How much baseline variability should you allow? And that is, if you have a run-in stage for 2 weeks, and patients on one day have a pain intensity level of 3, and then 4 days later it's 8, and 3 days after that it's 4, how stable does that baseline have to be? How consistent do they have to be? And sometimes the very simplistic factors that you look at, and this was a study published by Bob and Dennis, working with a group of 7 or 8 other collaborators, where, and again, you don't have glasses that are close enough to be able to read the conclusions in a situation like this. But essentially what their initial findings were was that when patients with a mean baseline pain of less than 4 out of 10 are included in an analgesic trial, the assay sensitivity appears to disappear. So you've got to have a minimum level of pain before. Our colleagues in acute pain, Bill Bieber, Ray Hood, and people who I consider my great grandmentors, have told us for years, patients have to have moderate to severe pain, so you have enough pain on which you can show an intervention has an effect. And yet, we were at meetings 2 days ago, 3 days ago, Andrew and I were in a meeting where one of the clinicians said, yeah, let everybody come in. And we have 10-15% of patients with mild pain, don't worry about it. Well, he did a study where he entered 1,500 patients on a clinical trial. I don't know about you, but my university can't afford a 1,500 patient clinical trial, so I can throw away 15 to 20%. And it also appears that patients who have excessive variability during the baseline pain on a 10-point VAS scale, if they change more than 2 points one way or the other over a 2-week period of time, they probably have too much variability for a clinical trial. Most clinical interventions depend on a more or less stable baseline to be able to draw any type of meaningful conclusion. The little cottage industry seems to have sprung up around this question. Can we improve the selection of patients for clinical trials? And can we train patients to be more observant? We all know that the large majority of patients who enter clinical trials want to please their clinicians. They want to tell you the good news that their pain improved. The fact of the matter is that in a clinical trial, we realize that there are some patients who, if they're randomized into a lower dose or into a placebo group, we really don't want reports of great improvement because that kills our clinical trial. And so the question is, are we selecting the right subjects? Are they careful enough? Can we train them to be more careful? And can we select those patients who really do comprehend the type of questions we're asking? This whole section of educating subjects, there are probably 4 groups who are now working in this area under the aegis of action in some way, shape, or form. Some of you may be working in this area as well. What we've seen is that there are different approaches to how best to train those subjects to try and be conscientious about their reporting. But interestingly enough, if you can ask other questions about the type of anchors that patients use, and it's interesting that when you speak to patients, and I've spoken to probably 50,000 in my career in clinical trials, I say, I'd like you to use this visual analog scale. 0 means no pain whatsoever. 100 is the worst patient you've ever experienced. And you say, by the way, what is the worst pain you've ever experienced? Right? If you're asking women, what do they usually come up with? Childbirth, right? More often than not. patients, it's jaw pain. Interestingly, a large proportion of patients that I speak to, and that was the patients who've had third molar surgery or they're having foot surgery, they say the worst pain I ever had was after I had my wisdom tooth extracted. And 40 and 50 and 60-year-old patients then say, you haven't lived yet. The toothache is the worst pain you've had. If you ask men what they use as the anchor for the worst pain they've ever had, what do they frequently come up with, Andrew? Have you asked individual patients?
Yes, it's very intriguing. I'm just going through my own head. I think it's a paper cut, personally, but then I'm...
Some will say a paper cut. Interestingly, if you ask men and they have gout, they'll talk about pain in their toe with gout commonly, or the other thing is renal stones, renal calculus. They have kidney stones, and passing a kidney stone, that'll bring you to your knees every time. That's until they have a herniated disc in their back. And so the question is, are all of those personal anchors created equal? I strongly suspect, like most other questions that ends with the suffix are blank created equal, they're not created equal. The question is, how does that impact their evaluation of drugs? And then several groups, Neil Singler, who was to be here, actually has prepared some educational scripts and interviews, and we're trying to run a couple of trials. Parallel trials where we look at those patients who have been through a training. Do they actually separate between active and placebo any better than those who've never been trained? And you just give our sort of standard education. So, I don't have answers for any of those questions that I've asked for you. But let me tell you that among the more embarrassing findings we've had, thank you, Dan, are we found that a number of papers we've looked at have really not adhered to this consort recommendation for reporting adverse events or harms. And it's interesting, in the early studies, the industry-based studies were much more adherent to these guidelines than university-based studies. University-based investigators, well, we're talking about efficacy of a particular intervention. We're not looking at side effects. And then recently, adverse event reporting in analgesic clinical trials, again, one of the bigger issues. There are actually 3 papers that have been prepared in this particular area. And I think one of the bigger impacts we've had is actually on journal editors and journal reviewers, because they realize we don't want to continue the process of just reporting positive news when indeed there are some harms that can be generated. And let the buyers be aware. And again, the same question that you asked before. If I'm selecting a low dose versus high dose, 15 or 30 milligrams of ketorolac, is there a side effect price that I have to pay? Well, most of the clinical trials aren't going to answer that. And if you're giving it in a single dose, you probably don't have a problem, as long as the patient has appropriate renal function. So, what is the impact of IMMPACT? It's been worldwide. There are, at last count, over 8,000 citations of these papers, and there's about 35 of those papers in very influential pain journals, including Pain Journal, Clinical Journal of Pain. There are, at this point, 6 other publications in process. And the findings on reporting practices appear to have raised the awareness of both authors, reviewers, and journal editors. I'm not quite sure how to count that effectively, however. I have individual one-off conversations with editors, but I'm not sure if there's a way to really document that impact. I can tell you, having worked in clinical research centers, in CROs, and in industry clinical research departments, these guidelines are looked at very critically to sort of see what they can learn as they design their next study. The one nice thing that it has created, and 4 of our young scientists have actually completed postdocs in Rochester or Washington in helping prepare, look at this data, critically utilize this data. So we're developing academics who really have an interest in reviewing clinical trials and clinical trial standards. And the point I would make was similar to Andrew's last slide, and that is the work's not complete at this stage. So if you have questions, and if you'd like to hear a little bit more or volunteer to participate if some of this work is of interest to you. Robert_Dworkin at University of Rochester Medical Center, urmc@rochester.edu, or Dennis TurkDC at uw.edu, or email me. I'm easy, I just put a couple of dots between my names and initials, middle initials, and we'll manage to connect you to some of the right people. But that's a pretty ambitious outcome. I would never have anticipated 12 years ago the breadth of the work that's been undertaken so far. So thank you very much.